Hi everybody, welcome to our first edition of Cafe Oncology. My name is Kristin Tenney and I am with Arizona Oncology, and I have the pleasure today to have Dr. Edgar Staren here to speak with us. Dr. Edgar Staren is a breast surgeon and general surgical oncologist here at Arizona Oncology. And today we're going to be talking all things breast disease. So the difference between benign and malignant breast diseases. And then at the end of Dr. Staren's presentation, you will have the opportunity to send in any questions, so feel free on the chat. So with that being said, Dr. Staren, I'll let you get started. Thank you again so much for being here today.
It's my pleasure, Kristin. Thank you. I will briefly discuss some of the most relevant anatomy of the breast. The breast is composed of a subcutaneous fat layer and a fat layer which generally surrounds, as well as being located between the breast lobes. Lobules are the terminal end of the various ducts, and which is where milk would be made. The ducts coalesce at the nipple. A normal duct is demonstrated in this image, showing a single layer of square cells, a basement membrane surrounding the cell layer and separating the duct from the surrounding tissue, which contains the blood vessels and nerves, and the lumen through which the milk or other secretions would pass towards the nipple. A great way to think about the breast is as a tree. So if you look where the nipple is located, that would be the trunk of the tree, and the ducts would be the branches, and the lobules would be the leaves on the tree. The breast is located on the chest wall between the second and seventh ribs and is superficial to a muscle called the pectoralis muscle, which is superficial to the rib cage and the intercostal muscles. A non-lactating breast weighs approximately 1/2 pound and is composed of 20 lobes. Each of those lobes has a duct or a branch passing to the nipple. There is a fibrous tissue network which acts almost like a suspensory cable on a bridge to support those lobes. The lymphatics of the breast drain into the armpit or axilla, where there are 3 different levels of lymph nodes located. There are a number of important benign diseases of the breast, and some of which can be symptomatic to the point of being quite bothersome, as well as confusing with other important diagnoses, including cancer. The diseases of the breast are categorized according to their variance of normal development, inflammatory, and other conditions. Within the variance category are both fibroadenomas and fibrocystic disease. Both conditions can present as a concerning breast mass. There are several inflammatory conditions which can occur in the breast, but apart from mastitis, which is associated with lactation, most of these are relatively uncommon. Among the other category, both nipple discharge and intraductal papillomas are relatively uncommon but can be quite important in the differential diagnosis of breast cancer. Fibroadenomas are very common, and particularly in younger women under 35 years of age. On exam, they feel smooth, movable, and rubbery, and in most cases are less than 3 centimeters in diameter. They were diagnosed by physical examination, mammogram, which shows solid masses, and particularly with a classic appearance on ultrasound. Fibroadenomas are hormonally dependent and can increase with pregnancy or decrease with menopause. On this slide, you see actually a gross anatomy of a fibroadenoma, but in the lower right-hand corner, you see an ultrasound image showing a lesion which is pretty smooth walls, ends up having an interior which is really homogeneous. That means regular and consistent, all indicative of the benign nature of this lesion.
Now, do these get bigger during your cycle?
They can, and actually they're very dependent on hormonal changes. It's why when someone goes through menopause and they're not having ongoing secretion of estrogen that they typically regress.
Okay.
The natural history of a fibroadenoma is such that more than 80% of them do not change in size after they're diagnosed, but approximately 15% may decrease in size, and the ones that concern us, of course, are that 5% which increase. When considering how to treat a patient with a fibroadenoma, it's important to consider whether the mass is palpable or non-palpable. In other words, non-palpable, did we detect it simply on a mammogram? what its appearance is on studies such as ultrasound, such as the one we just saw, and what is the lesion size.
Okay.
Finally, what's the patient's preference for treatment? Do they want it out, regardless of the pathology? These lesions may undergo a core needle biopsy, and if that confirms it as a fibroadenoma and it's not palpable and not bothersome to the patient, you can leave it alone. It's safe to observe it.
Okay.
However, if it's increasing in size, if the pathology is questionable or of concern, and finally, if the patient simply desires it to be removed, then it should be.
Good to know.
Fibrocystic breast change is very common. When I was a medical student, we used to call it fibrocystic breast disease, but it occurs in more than 50% of women over the age of 30. So I used to say it's like calling brown eyes a disease. Its management really depends on the type of pathology, which can vary from ductal hyperplasia, characterized by an overgrowth of normal cells, to the other extreme of gross cystic disease. And in this case, you see both gross cystic disease in the middle of the slide, as well as over on the other end, the hyperplasia. We would tend to refer to the hyperplasia side as those dense breasts that we'll see in fibrocystic, whereas the lumpy breasts are the gross cystic side. Approximately 1/3 of patients will present with one cyst, about 1/3 will have multiple cysts, and 1/3 will have diffuse cysts involving both breasts. If a breast cyst is asymptomatic and demonstrated to be a simple cyst on ultrasound, it may be observed. If the cyst is painful or suspicious looking or complex, it should be aspirated, such as is the case in the picture on the right. A very important variant of ductal hyperplasia, and which occurs in about 3% of patients, is atypical ductal hyperplasia. In this case, there's an overgrowth of abnormal or atypical appearing cells. This diagnosis increases the patient's cancer risk by 4-fold. More specifically, they have an approximately 0.5% risk of developing a breast cancer each year. You'll notice in this one that under the normal, you have that nice single layer of cells in a circle, whereas in the middle, the ductal hyperplasia, you start to get a bit of an overgrowth, but they're all normal-looking square-type cells. Finally, the atypical ductal hyperplasia, which, as I mentioned, has an increased risk of breast cancer, ends up having very irregular cells. And if a pathologist looked at one of those cells under the microscope, it would look like a cancer. When we do a biopsy, an analogy I like to give is that you're doing a biopsy like you have a scoop of jelly beans. Green jelly beans are good, yellow is concerning, maybe the atypical, and red is a cancer. And all you see is green jelly beans. Well, if we do a core biopsy and we take that scoop and we see a yellow jelly bean in there, we have to worry. We didn't see that yellow one. All we saw were the green ones. Could there be some red ones in there as well, which are disconcerting? And in fact, the incidence is about 15 or 20% of the time we'll actually have an upgrade from that atypical hyperplasia to a carcinoma.
Okay.
And so the rule of thumb, if someone has a core biopsy that shows atypical ductal hyperplasia, we need to do an excisional biopsy. Nipple discharge is relatively uncommon in a non-lactating breast, but it can be an important differential diagnosis. When examining such a patient, it's important to determine if the discharge is from one or both breasts, is it spontaneous or only induced with pressure on the breast, and what's its characteristics? Specifically, is it milky, bloody, green, serous, clear? Discharge which is unilateral, spontaneous, in other words, it comes out on its own, and bloody or clear likely needs a biopsy. Dark fluid, like blood, is most often found, however, to be a benign intraductal papilloma, in fact, about 60% of the time. When the fluid is greenish or light yellow in color, it's most often a benign diagnosis of ductal hyperplasia, about 1/3 of the cases. Galactoceles can occur after a woman has completed breastfeeding, even sometime afterwards, and generally is milky, whereas carcinomas are of concern when the fluid is clear or bloody. Breast cancer is obviously a devastating diagnosis, and one of the important reasons to talk about those various other benign entities is, as you now know, they end up being a potential risk for that diagnosis, so it's important to understand the difference. Breast cancer affects 1 in 8 women during their lifetime. Unfortunately, this year in 2022, nearly 300,000 cases of invasive breast cancer and over 50,000 cases of non-invasive ductal carcinoma will occur. Even more unfortunately, over 40,000 patients will die related to breast cancer. However, and I always think this is important to note, we've now made advances. Over the last 3 decades, the mortality from breast cancer has continued to decrease. And you'll notice that decreasing, which is ongoing on the bottom part of this slide. So I remain optimistic about the future.
Yeah, that's great news. It's so reassuring to see the numbers going down.
It is. Part of it certainly was related to just increased screening and earlier identification of breast cancer, but some of it's the remarkable advances that we've made in treatment over the last few decades. In considering a possible diagnosis of breast cancer, it's important to know how long a lump or new problem has been present, a history of previous breast problems, and particularly previous breast biopsies, and their pathology are important. We talked about the atypical hyperplasia pathology. Other symptoms such as nipple discharge, changes in the skin or the nipple of the breast, or in particularly new or focal breast pain should also be determined. On physical exam of the breast, the patient should be examined in both the sitting and the supine positions. If a mass is present, it should be examined to determine characteristics such as, is it smooth versus irregular, is it hard versus soft, etc. It's important to look for differences between the right and the left breast. You can do a comparison there. And in fact, it's helpful for the patient to be able to do the same thing. You should review for changes in the skin or the nipple and evaluate abnormalities such as enlarged lymph nodes. I think it's worthwhile just to pause here and remind patients that while the majority of early breast cancers are identified by mammography, we still see an enormous number of patients that identify a lump themselves and bring it to the attention of their physician. And patients will routinely tell me, Dr. Staren, I don't know how to examine my breast. I've got lumps all over the place and they change, etc. So what I will tell them is draw a picture of each of your breasts and divide it into quadrants. Draw a line straight through the nipple up and down and then one sideways, and then examine the breast in that quarter and map it. Go right to your drawing and draw if you feel a lump or it's just kind of dense. If it's dense, draw a bunch of straight lines. If it's a lump, draw a circle there. That map then should be brought to the attention of your physician if you feel something unusual or different. And then you can use that in the future to compare.
Now, when you say your lymph nodes, so should women be checking their lymph nodes, and is that considered under your armpit area?
That's a great question, and they should as part of the examination because it can be a presenting sign. It turns out that more often, however, if someone ends up having a swelling of the lymph nodes, we start to think about hematologic issues, things that might be related to lymph node tumors.
So we have a question. Sonia would like to know about thermal imaging. Do you think it's a good way to test, or is using traditional breast scan methods better?
The traditional breast scanning methods are still better. Thermography is based on the fact that breast cancers have a higher metabolic rate. They reproduce faster. But there are benign lesions that do that too. So there's an awful lot of overlap. And the fact of the matter is some cancers can be relatively slow growing and not be shown on thermography at all. So screening modalities of mammogram and ultrasound are clearly the most advantageous, mammogram being number one. And then depending on the circumstances, you may go to a different level, such as magnetic resonance imaging, as the next level of evaluation.
Sure. Yes, I'm high risk, so my doctor recommends me getting an MRI alternating between mammogram.
Well, we can talk about that when we get into the question section a little bit, because the evaluation of a person at high risk, those with familial histories such as the BRCA genes, are very different. And in those cases, we recommend that they start evaluations even as early as 25 with MRIs, and then alternating MRIs with mammograms every 6 months.
Sure, that's what I
For that reason. And we'll talk more about that in some detail. Let's see here. We talked just a moment ago about screening mammograms, and really, what are you looking for on a screening mammogram? Well, in this slide, you see 3 examples of mammogram with identified suspicious lesions From the left, you end up seeing a suspicious mass, a very specific mass. Microcalcifications in the middle and asymmetric density. Now, if you haven't looked at much of these before, it looks like just kind of a bunch of clouds up in the sky. But there's two important things to note. One, in the last decade, 15 years, we now use digital mammography. And so we have enormous advantages as opposed to standard film screen, which you can't adjust like you can with a digital image. Just like on your computer where you can enlarge a particular area, you can do the same thing with a mammogram and hone down to an area to determine if a group of little calcium deposits are suspicious looking. In other words, do they look like little linear branches, or versus benign type calcifications, which just look like little dots. That's an important distinction and can determine whether or not a person needs a biopsy. So it's part of reinforcing the importance of these mammograms as screening technology. To put it in more specific terms, the recommendations for screening mammograms have varied, particularly over the last 40 years. The question of whether or not screening mammograms are of value was pretty much put to rest with a large meta-analysis, which refers to a study that looks at many different studies and accumulates all that data. It was reported approximately 25 years ago, but the data on that hasn't changed dramatically. It showed a significant reduction in mortality in patients between age 50 all the way up to age 70 who underwent screening mammography. Where there still is a little bit of controversy is demonstrated in the next slide, and that's in the 40 to 50 age group, where there's a slight improvement, but it didn't reach what we refer to as statistical significance. But we still have enough concerns that the recommendations for screening mammogram are pretty much as follows, despite this controversy. The American Cancer Society has come out with the recommendations for biennial mammograms beginning at age 40. That means every 2 years, annual mammograms between age 45 and 54, and resuming every 2-year mammography at age 55. You should note that these recommendations apply only to individuals who have no signs or symptoms of breast cancer. In other words, you come in with a new breast lump that's suspicious on physical examination and you're 35 years old, you're going to get a mammogram, and that's appropriate because it helps evaluate not only that area but the other breasts. Those women with signs and symptoms, such as I just described, should be getting a diagnostic mammogram based on that presentation. Here's an example of a mammogram on the left, and this is what we call a magnification compression view. So if someone gets a screening mammogram and we see something abnormal, we can then adjust the films or even do additional studies by compressing a particular area and determining if it was just some dense tissue that pressed out and which is benign, or if we compress it, it actually confirms that there's a mass lesion there, which tells us it needs a biopsy. We can also perform an ultrasound. If we see a mass lesion on the mammogram, we can perform an ultrasound and see whether or not it's something that's suspicious or something that's benign. Now on the left side, if you end up doing this particular lesion, you can see it as a simple cyst. It's obvious and we don't have to worry about it anymore. If you see that, then it's asymptomatic, it can be safely observed. On the other side of the coin, if you see something like on the right, notice that it has very irregular edges to it, all right? It ends up having this weird kind of shadowing behind it, a whole host of different categories and characteristics that tell us that this is likely benign. You see something like that, we need a tissue diagnosis to help us know what to do. This is an example of an ultrasound-guided core needle biopsy, and we can do this right at the same setting. Someone comes in and they end up having a mammogram that shows a lesion. We perform an ultrasound and it shows to be suspicious or solid. We can get a piece of tissue right at that time, get that off to our pathologist, and within 2 or 3 business days have information back to talk to the patient. Then if it comes back and it shows that cyst, we can tell them not to worry about it and nothing more need to be done. Most lesions are identified by mammography, but you'll notice in this one, in that red circle, there's some those calcium deposits we talked about. Now remember I said that the breast is the shape of a tree and that it has more and more distal branches. Well, if you end up having a carcinoma, a cancer that forms in those branches, that inflammatory process can cause calcium deposits to form. Those calcium deposits, as consistent with the branches, will have a linear or branching kind of a characteristic. In this case, we see those linear branching calcifications, so we know it needs to be biopsied. We're suspicious of that. But you can't see that on ultrasound. So we use the mammogram and what's called a stereotactic biopsy to perform that information. It'll give us a sliver of tissue, which is plenty for the pathologists. And in fact, here you can see on the left, there's a notch within that needle, and this is approximately 2 centimeters, so a little less than an inch long piece of tissue. Now that doesn't look like much to us, but to the pathologist it's a lot. So they can take that tissue, make stains and slides of it, as you see on the right side, and make a definitive diagnosis, in this case, of an invasive carcinoma, and then we can make recommendations and treat that patient appropriately. It's important to understand that there's a number of stages of breast cancer. They're not all created equal. And fortunately, the majority of patients come in and end up having a stage 1 breast cancer. In fact, 2/3 of patients have a tumor that is underneath 2 centimeters in size, so well under an inch, and they do not have any lymph nodes involved. So it's truly localized to the breast. Stage 2 are slightly larger tumors and may have positive lymph nodes, but it's usually microscopically involved. And stage 3 are larger tumors. They're greater than 5 centimeters, so the size of a lime, if you will. They have positive lymph nodes. They may be larger involvement of the lymph nodes, and therefore can be advanced. It might even involve the skin or the chest wall. We refer to stage 2 or stage 3 as 30%, as being 30% of breast cancers. But the thing to note is 95+% of the time, breast cancer is localized. It's either within the breast or the localized area of those lymph nodes. And what's even more important is if we identify breast cancer, it is true that the cure rate is greater with a stage 1 than it is with a stage 2. It's greater with a stage 2 than it is stage 3. But overall, 90% of patients that come in with a stage 1, stage 2, stage 3 patients are alive at 5 years, therefore what we define as cured. For nearly 100 years, unfortunately, breast cancer was treated at that time with radical mastectomies, which was defined by a surgeon called Halstead. Those were aggressive treatments. They caused deformity. The patients would have all the lymph nodes removed in the armpit. Actually, I'm still young enough but old enough to have seen the last radical mastectomy done when I was an intern at the institution that I was trained in. So it's not like it's that long ago that these were still being performed. The modified radical mastectomy required less removals, but it certainly was still an important procedure. What astounds me is how recently we talk about breast conservation therapy where we just removed the lump. It wasn't until 1991 that the NIH came out with a consensus statement which concluded that the survival for breast conservation therapy, that is just removal of the lump, the cancer, and treatment of the lymph nodes and the breast, etc., was equivalent to a modified radical mastectomy. There have been further developments that have been important, and that includes what we call a sentinel lymph node biopsy. Again, when I was in my training, we would do a majority of the lymph node dissection, certainly the lower level nodes, level 1 and even level 2, which had in and of itself a not insignificant risk of causing lymphedema and arm swelling. In 1994, what was described was just identifying those lymph nodes that are most likely to be the site of metastatic disease. It's based on administering a dye, usually blue in color, that localizes to those sentinel nodes, as well as administering a radionuclide which focuses in that area. And we use little gamma counters to be able to detect where the lymph nodes. And so we will remove 1. The most I've removed at any sentinel node is 6. And that gives us the information that we need to know whether or not that tumor has jumped. What's even more exciting and an even more significant advance is data now indicates that if a person only has microscopic disease involving 2 of those lymph nodes, they're done. They don't require any further dissection of those lymph nodes. That's an adequate treatment of that armpit. As such, breast conservation therapy now includes a partial mastectomy, also called a lumpectomy, an axillary sentinel lymph node biopsy followed by radiation therapy to the breast. That's still important. And the reason we know that is that there can be a second small area of breast cancer just outside the area of the primary. If you don't give radiation therapy and you do only a lumpectomy, the chances of recurrence in that breast is about 20–25%. If you radiate the breast, you decrease that chance of recurrence in the breast to about 3%. So each one of those parts are important. Also of note, today about 70% of patients, so more than 2/3 of patients, are candidates for breast conservation. There are some that are not, and there's contraindications. For example, if someone's had significant chest wall radiation already, perhaps for Hodgkin's disease or other entities. Positive margins, in other words, if we do our lumpectomy and there's multiple areas where we see additional tumors, those patients really should not have a lumpectomy. Multicentric disease, in other words, you do your mammogram and you see cancers in multiple areas of the breast. It's not going to help to just take out one. And then finally, an entity called inflammatory cancer. Inflammatory breast cancer involves the skin, and you'll get red changes over at least 1/3 of the breast, and those are very aggressive and should be treated by mastectomy, and usually in conjunction with chemotherapy, even before you do the mastectomy. I'd like to finish with this hopeful slide. We started in the beginning with the incidence of breast cancer and showed that we're seeing a decrease in the number of patients that are dying of this disease, and I think that that's going to continue. And the reason I believe that to be the case is because of these many advances in breast management. For example, we now do what's called oncoplastic type techniques, where patients that weren't really candidates for breast conservation in the past, by virtue of some of the technologies and the approaches that are used, allow them to be. The reconstructive procedures and how we end up doing that, both with implants or with native tissue, flaps that are rotational flaps from the latissimus muscle or from the abdomen, have also increased our opportunities to be able to give important reconstruction to patients and be very aware and address body self-image. Radiation is improved. We do localized radiation therapy in some circumstances and not have to radiate the whole breast. In the past, radiation would involve 5 days a week for 6 weeks. Routinely now, breast cancer is treated in 3 weeks with an entity called hyperfractionating, where we slightly increase the dose of each day, but get the patient through that treatment quicker with no decrease in the recurrence and survival rate. And then finally, intraoperative radiation therapy in some circumstances, radiate the patient right at the time of surgery. Lastly, medical oncology, there's been huge advances in immunotherapy and targeted therapies. Treatments aimed at what's called the HER2/neu receptor has changed the whole game as far as breast cancer. And then neoadjuvant, I mentioned that with some of these patients that end up having aggressive cancers. We can convert a cancer to one that was not a candidate for breast conservation and actually shrink it on down to making those patients candidates for breast conservation. So very excited about what's occurring in breast cancer, and I think it bodes very well for the future.
Thank you so much, Dr. Staren. I know we have time, so if anybody wants to submit questions, I have questions myself that I would like to ask you.
Great.
So, Dr. Staren, what do you think are some of the misconceptions about breast cancer?
I think that with any cancer, one of the misconceptions is that I get that diagnosis and I'm not going to live. And as we talked about, the vast majority of patients present with localized, if not regional disease, and the vast majority of those patients are cured. Now, it is true that the treatments are not easy, and I speak from experience as a cancer survivor, not a breast cancer, but cancer nonetheless, and know that it was tough. But I'm 15 years now and doing very well, and I think that patients that end up having that diagnosis should view it with optimism given the advances that have been made.
Okay, that's great. Are there things that people can do to reduce their breast cancer risk, like with their diet or their alcohol intake? Do those work? And should they implement some of those things?
It is true that there's certain things that do increase the risk of breast cancer. One, exercise, staying fit ends up being one, and we believe it's related to weightedness of the person. In other words, an obese patient has a higher risk of breast cancer than a thinner patient, and it's probably related to the fact that there's an increased estrogen production in the patient that is overweight. because of tissue conversion in the periphery. The more fatty tissue they have, the more of that conversion. They also, it's absolutely true that a person that's more fit, if they do have to undergo treatment, will be able to tolerate the treatment better. And so we're able to be more aggressive in being able to treat their cancer. There is an association between alcohol and breast cancer. And so significant amounts of alcohol every day does increase the risk of breast cancer. And so everything in moderation is probably the best way to view it. I'm not one to say that people shouldn't have alcohol, because I think that's a personal choice, of course. But again, everything in moderation.
Sure. No, I think that's helpful to women to understand, like, you know, to keep it, it shouldn't be every day, just to watch how much you are drinking. I think that's all helpful. Okay. How often should a woman do a self-exam? Is this something that should be done monthly? Is there different times of the month that are better? What is your recommendation?
Yeah, this is one of those ones that's very controversial. There are those out there that say don't do breast self-exams, and yet at the same time, the majority of breast cancers are still identified by women feeling a lump in their breast and or a symptom and bringing it to the attention of their doctor. I still recommend patients do monthly self-exams, and I tell my patients to do that regularly for the reasons I just mentioned. I will show them how to go ahead and, in fact, it's not going to be fancy drawing here, folks, but I think it really is the kind of thing, and this is what I'll do with the patient. I'll say, just go ahead and draw the breasts on both sides and divide it up into the quadrants that we talked about. So if you end up having the right breast, I'll tell the patients, go ahead and examine the right upper quadrant towards the armpit, down below, medial on both sides. And if you do feel something, so if you felt something that was just kind of density, the breast is very dense, just go ahead and draw some lines in that particular area. If you feel a lump, go ahead and draw it as a lump. If you feel something that's suspicious or gives you concern, bring that to the attention of your doctor.
Okay, all good tips. How about high risk? We talked about that briefly.
Yeah, there's really the two big categories are the BRCA1 and BRCA2 genes. And the second area is what's called Lymphadenectomy, and it is also a familial but much less common than the BRCA1 and BRCA2. So let's focus on that, but there are some generalizations. If a person ends up having those particular genetic changes, they are absolutely at a higher risk for breast cancer, but they're also at higher risk for other cancers. For example, they're at a higher risk for ovarian cancer. The incidence of breast cancer in patients that are BRCA positive, BR for breast, CA cancer, ends up approaching 80%. For ovarian cancer, it approaches 40% during the course of their lifetime. They also, it's not limited to just women. Patients that are BRCA positive, it is inherited as what's called an autosomal dominant. So there's a 50% chance, if one of your parents have that genetic change, that genetic mutation, that you can inherit it, either a male or a female. And a male would have risk because they may have pancreatic cancer and or prostate cancer. There's a slightly higher risk of both of those, and both of those, of course, can occur, at least the pancreatic cancer in a woman. So what do we do in those circumstances? Well, with breast, we initiate, as you pointed out, doing studies, mammograms earlier. Ultrasound for a screening probably doesn't play as much of a role. If you do the mammogram and you see something, you may progress and then do the ultrasound like we talked about. This may be a cyst or maybe something solid, and then maybe use that for a biopsy. MRI is a test that is very, very sensitive. It can pick up lesions that are not always picked up by mammogram and ultrasound. We actually inject a dye that helps us because you'll show enhancement of the particular lesions that might be suspicious. But it's not an easy test. MRI can be uncomfortable for some people to take, and it's expensive. So it's not one that's going to be a screening test for everybody. It also has a second difficulty, and it's not very specific. In other words, it picks up everything. And so if you end up doing MRIs on everybody, many people will get biopsies for things they just don't need. So mammogram, ultrasound for everyone, all right? MRI is important in those circumstances with a patient with a high risk. And actually what's recommended is in a patient that's BRCA positive that they begin MRI at age 25, that it's annual until age 30, and then beginning at age 30 they alternate, as you pointed out, every 6 months, mammogram, MRI, etc. And that'll go on in at least until age 70 if they're undergoing observation only. There are, and it goes kind of beyond what we're talking about today, but in those circumstances, beyond doing screening studies, there are some recommendations that can occur to help prevent the development of breast cancer. And so there's discussions on doing preventative mastectomies at those patients, and much of the discussion is at what age does that occur. It affords us the opportunity to be able to do skin-sparing mastectomies, which means leave the nipple and areola and do immediate reconstruction. There's also, because of the difficulty in screening for ovarian cancer, there's just not great markers that help us with ovarian cancer. And even things such as transvaginal ultrasounds or abdominal ultrasounds are not particularly specific. So there are recommendations to perform oophorectomies, removal of the ovaries, once a person is past childbearing years.
Sure.
All right, and those are critical discussions. Should
Sure.
a woman have those kinds of genetic changes in that high risk, it's critical for them to speak with a genetic counselor, to speak with their physician, presuming the physician is knowledgeable in this area about what their risks are specifically and what the recommendations might be.
So do you recommend any woman with a family history of breast cancer, should they be getting tested for the BRCA gene?
There are strong indications for when that should occur. If a patient ends up having a personal history of breast cancer and they end up having a family member that ended up having a breast cancer under the age of 40, there should be BRCA testing, and their families should be as well. If you end up having a breast cancer relative, especially second-degree relative, etc., and they may have had a breast cancer over the age of 60, with 1 in 8 women being at risk for breast cancer during their lifetime, if we use that as a basis for genetic testing, everyone would get genetic testing. And so I think it's important to utilize the various guidelines that have been defined by some of the key organizations, American Cancer Society, American Society of Clinical Oncology, etc.
Okay, thank you so much. That was so helpful.
Great.
Anybody else have any questions? No? Thank you so much, Dr. Staren. This was so helpful. I appreciate it. I know many women have so many different questions, and ladies, get your mammograms. So thank you so much. I appreciate you taking your time out today to talk to us.
It's my privilege.
Thank you.
Kristin. Thank you.